Welcome to the 41st edition of Searchlight. Today, we have friends who have joined in as faculty from Anantapur, Bhimavaram, Hyderabad, Nalgonda, and Raipur Obstetric Gynec Society. We also have respected Narendra Malhotra sir as our chief guest. We have Dr. Manjula Virmani ma'am from Delhi as our speaker, and we have Dr. Samira as our chairperson. So, Dr. Sujayasri Sangita is the secretary of Bhimavaram Society, is my convener. She is a consultant obstetrician and lab surgeon at Sheshadri Hospital, Palakol and Malkapuram. She is the founder secretary of Bhimavaram Society. She has many awards. Her areas of interest are laparoscopy and infertility, has many paper presentations, has organized many academic events, and conducts awareness program in the name of Vikasam for adolescent girls. So welcome, Sujya. I would like to introduce my coordinator, Dr. Purvi Agrawal, who's an executive member of Society of Fetal Medicine, Raipur. She is Director and Consultant Fetal Medicine at Krishna Fetal Medicine Center, Executive Member, Society of Fetal Medicine, Chhattisgarh, past IFS Executive, IOTA and FMF certified. She is trained in fetal procedures, has many national and international publications, and is a training faculty at my hospital for Foxy recognized ultrasound. So I would request Purvi to give a brief introduction about me before we take the program forward. Welcome, Purvi.
Thank you so much, ma'am. I would like to welcome everyone to this 41st Searchlight, 41 Wednesdays of Enlightenment. I would like to take this opportunity to introduce our program director, Dr. Asha Jain, ma'am. Ma'am is director at SMSA Hospital, Raipur, medical director of Cancer Prevention and Relief Society, elected member CG Medical Council, CP elect Foxy FDMSE Committee, President Raipur Menopausal Society, Chairman Mission Pink Health IMA Raipur, Executive Member of ISCCP, CGISAR and CGSFM. Her interests are preventive oncology.
I think that's it. So now I would thank you, Purvi. Now I request everyone to take the blessings of the divine before we take the program forward. Welcome all. I take this opportunity to introduce our chief guest for the evening, Dr. Narendra Malhotra sir, who's the past president of Foxy, and that's not just it. This is his CV. He is the managing director of Global Rainbow Healthcare, Ujala Cygnus Rainbow Hospital, Director ART at Rainbow IVF, Director Foxy Smriti Manyata CSC, VP of Society of Ovarian Rejuvenation, Director Project Positive Health Rotary District 3110, Director International Relations CEFOC, National Director Ian Donald School of Ultrasound, Professor Sarajevo School of Science and Technology, Croatia, Professor Dubrovnik International University, Croatia, VP SAFOG and WAPM, past President Rotary Club, Agra Taj City, past President Isar Ispat, IFUMB, Foxy, AOGS, ICMU, and INSARJ, founder editor, SAFOG Journal, member of FIGO Guidelines Committee, Chairman Smriti. He's an advisor to Maulana Azad Medical College, JNMC Aligarh, and SMS Medical College, Jaipur. If I go on reading, it would take me another half an hour to describe, sir. He is with us. I request
Thank you,
sir, for your blessings and words of wisdom. The topic today is Adnexal Masses.
A very good evening to all of you. It's indeed a pleasure to be here on this Searchlight program. I apologize that previous Searchlight program I did miss because of some previous appointments. This is such a unique program which I was looking back, that you focus on one thing and then discuss it threadbare and come out with clinical guidance for the practitioners and for everyone. As we know, adnexal masses are the most complicated masses which you can come across. Even a small cyst, a hydrosalpinx, a TO mass, all fall into adnexal masses, and they are diagnosed and misdiagnosed and overdiagnosed by ultrasound. And a lot of times the age of the patient varies. Small cyst in a postmenopausal woman could come out to be malignant, which does not look malignant, and a large cyst, which in a young patient, which is simple, could be just benign and all that. So we have a great ultrasound offers the best methodology to evaluate the adnexal masses. And as you know that we have the IOTA scoring. IOTA is the International Ovarian Tumor Association, which a group of doctors sat together for 5-6 days, weeks, and discussed threadbare on how the adnexal masses should be diagnosed and what markings should be given so that we can divide them into benign, intermediate, and malignant, and suspicious, or even undeterminate. And undeterminate, then you go for an expert opinion and how you can put the biochemical markers and cancer screening markers along with this, like CA125, like HE4, like Roma, like RMI index, and make out the or do the analysis that this adnexal mass could be malignant. And we have no better person today than Dr. Manjula Virmani, who's my very, very close friend from long time of the IFUMB years, when I was a secretary 20-30 years back. And then with Manju, we've worked on a lot of projects in ultrasound. So I'm sure we're going to have a great discussion on how to go about screening adnexal masses, how to define benign and malignant confidently, and where to take a second opinion, and how to use color and maybe 3D also in these. So congratulations, Dr. Asha Jain, and congratulations for taking over this Food and Drug Committee from January. And I'm sure we'll do much more searchlights and take education to the doorstep. Thank you for inviting me here to give my opinion. Thank you very much.
Thank you so much, sir. Really honored to have you with us, and you yourself being, so much into ultrasound. Means I have been in Foxy for 30 years and I've been watching you with ultrasound for all those years. So I'm really honored to have you. Purvi?
Yes, ma'am. So for our first session, I would like to invite Dr. Samira Aluri ma'am as our chairperson. Ma'am is a senior obstetrician and gynecologist, sonologist, preventive oncologist, and vaginal surgeon. She has a Vijaya Vamsi Clinic at Somajigoda and Sri Holistic Hospital, Nizamapet Road. She is the main consultant. The Obstetrician Gynec Society of Hyderabad, Ma'am has MD from Osmania, and diploma in USG in ultrasound from WHO Collaboration Center Zagreb and FICOG. Ma'am is a member of FOXI, IAGE, SOV, SI, and IMS. Ma'am is interested in practical obstetrics and high-risk pregnancy, fetal medicine, adolescent health, contraception, NDVH preventive oncology. She has presented paper in national international conferences and chaired many sessions in national international conferences. Ma'am is passionate about breastfeeding promotion, and her hobbies are meeting friends, gardening, singing, reading, cooking, and definitely medical counseling. Very warm welcome, ma'am. I would like
Thank you so much.
I would like you to introduce our speaker for today, Dr. Manjula, ma'am.
Good evening, everybody. Thank you so much, Asha Di, for inviting me as chairperson. This is my honor to introduce Dr. Manjula Virmani, madam. She is expert in ultrasound. Today's her topic is ultrasound evaluation of Adnexal Masses, benign versus malignant. She is a consultant radiologist in Handa Imaging Center, New Delhi, India. Education, she is educated from medical school, Lady Hardinge Medical College and Hospital, Delhi. Postgraduate in radiology, Harvard University Hospital, Washington, D.C. Fellowship in breast imaging and ultrasound, Washington, D.C., USA. Board certification in radiology from American Board of Radiology. Her interests are field of women's health with special emphasis in obstetrics, gynecology and breast imaging, and 3D, 4D ultrasound. Affiliations are Vice President AFSUMB, Asian Federation of Ultrasound in Medicine and Biology, 24 to 26. She is Vice President. Dean ICMU 2024 to 2025. Convener of IFUMB outreach programs in India. Involved in multiple CMEs and teaching programs, both national and international level. Past President, IFUMB, October 22 to October 2023. Past President, Delhi Chapter, IFUMB. Member, IRIA, Society of Fetal Medicine. I welcome you, madam, to give your deliberation.
Thank you so much for introducing me. It's a pleasure to be with you all. And thank you so much for the organizing committee to invite me to be here. And it was very nice meeting Dr. Asha Jain and Dr. Narendra Malhotra, who I'm meeting after a long time. So I would be speaking on okay. Just one second, I'm just trying to connect it. Okay, can you all see my screen?
Yes, ma'am.
Okay, so I'm going to be talking on the IOTA, which is International Ovarian Tumor Analysis, the Adnex model, and I've also added ORADS because I personally prefer ORADS, which has simplified the risk version. And like Dr. Malhotra said, it's one of the very common clinical challenges which we have when we are trying to characterize an ovarian or an adnexal mass. And here's one such lesion. If I was to describe it, I would still say multilocular with an echogenic component and extreme vascularity. And I really can't at this time give an answer. Hopefully by the end of it, we'll all be able to work out together. So IOTA framework involves definitions, morphological description, and measurements. And basically, because of this, they characterize an ovarian and adnexal mass using subjective evaluation, which is pattern recognition approach. And then there's an objective evaluation where we use the simple rules, descriptors. We'll use these models, Adnex models, and try to come to an answer. And I definitely recommend this particular paper, which is by this particular group, and it's an excellent paper, which I think we all should read it. So I'm going to try and simplify it, but let's see what we can do, okay, in this. So when we are using subjective evaluation of using pattern recognition approach, we have these two images. This looks like a complete anechoic cyst, and this is a multilocular cystic mass. So when we use this, we can accurately characterize about 90% of the adnexal masses. That actually improves the diagnostic accuracy in differentiating with benign and malignant lesions, with almost a sensitivity and specificity of about 90%. So we can say that this is heading in more for a malignant lesion, and this is a pretty clean looking benign lesion. So what is this thing? What is the definition of ovarian lesion or an adnexal mass? It's a part of an ovary or an adnexal mass that from ultrasound assessment is inconsistent with normal physiological function. Now here we have a cyst and the ovarian tissue is being compressed. So it's possibly that this ovary is not functioning that well. And also in this this thing, where it's an ovarian complex, we actually can't differentiate any normal ovarian tissue from this multiloculated complex, a multiloculated mass. So part of the ovary which is consistent with normal physiology is not a lesion, which may be a stimulated follicle, which may be a corpus luteum or a luteinized follicle, and we will come to their features a little later. Now, just a little bit of definition of some of the descriptions which we use to describe these adnexal masses is a septum. Septum is nothing but a thin strand of tissue running across the cyst cavity from one wall to the contralateral wall. It may be thin, it may be a little thicker, as we can see here. And sometimes these are incomplete. Incomplete is when they come from one wall, but they do not touch the other wall in any of the ultrasound imaging. I mean, we change the angles and it doesn't change. And this is usually seen in hydrosalpinx, which is an incomplete septum. Solid texture refers to tissue with higher echogenicity, and that tissue we compare it to the adjacent myometrium. Here we have one solid looking mass. There is this cystic mass, but there is solid papillary projection, which is projecting from the cyst wall into the cavity. Then, we are having these small papillary projections, and if we are not sure whether they are solid lesions, we can put in color and they just highlight with color, and that actually tells us it's a solid lesion. The blood clot is not considered a solid component because even though it looks echogenic, but when we are trying to scan, if we try and move it, it moves and it jiggles with your probe, this thing, and it's avascular. It is not a solid component. Endometriotic cyst, when they have the sledge which settles down along the internal wall, is again not considered to be a solid component and this hyper-reflective area, which is the white ball in the dermoid cyst, is not considered to be solid tissue. Now, when we use all this, they are further classified into these 5 categories, and we'll try and go through each of them, starting with unilocular. Unilocular is when there's a single locule. We don't see any septa, we don't see any solid components or any papillary projections. And this is just a 3D image highlighting this. And then sometimes we do see normal compressed tissue, which is along the wall, and that is not a solid tissue. In hydrosalpinx, there's an incomplete septum, and that is considered as unilocular because it does not reach the other wall. Then if it's a smooth cyst, but there's a small papillary projection, this is just considered an irregularity, especially if it measures less than 3 millimeters. If it's an irregular internal cyst wall, but these are measuring less than 3 millimeters, just considered an irregularity and not a solid lesion. The other distinct lesions which are in the unilocular group could be this endometrioma, where we said that the sludge is along the internal wall. In a fluid level, this is a patient with endometriosis. We can see one of the cystic components, which has classic features of endometriosis, and fluid level. Then in case of dermoid, again, this is not a solid tissue, and this is considered into a unilocular focus. And in a peritoneal inclusion cyst, we have this large cyst, and we see this multiple ovarian tissue being along the edge of the lesion. And coming to unilocular solid, these are the lesions which show a measurable solid component. And there has to be at least one papillary projection. So here we can see that there's a cyst mass, but there is an echogenic focus which is projecting into it. Here's another one which has again an echogenic, a larger one with multiple smaller papillary projections projecting into the cavity. This is another patient which actually shows an echogenic component. And if you look at it, this is the acoustic shadow which is going on. And this is classic for one of the ovarian cancers. Then we can have another, this thing, there's a 3D image. Now here we see this echogenic component and we put in color flow to make sure it is solid tissue. And, but this, I mean, this is one of the unilocular solid tissues. The other examples are when there is at least one papillary projection which is measuring than 3 millimeters. Here's another one which is more than 3 millimeters. Then in hydrosalpinx, when we see the opiosalpinx, when we see a lot of increased internal echoes and we see these echogenic nodules which are along the periphery. And when we also see in hydrosalpinx the beads on string appearance. So these are considered as unilocular solid. Coming to multilocular, multilocular is cyst with at least one complete septum which runs from one end to the other. There is no solid component or no papillary projection. And these are two different examples of a multilocular septum. Then sometimes what happens is that these cysts start showing these low-level echoes, which is mucin, and they start collecting in these locules. And when sometimes they become so echogenic that they look like a solid component that is not a solid component, but thick mucin, which is getting which is seen in this region. Then we have multilocular solid, and these are the lesions which have to have measurable solid components, at least one papillary projection. So here's a multiloculated mass. There's a cystic focus projecting inside the endometrial, inside the cystic mass, and then we have multiple ones along the edges. There's another solid component sitting at the base. This was a multiloculated cystic mass with a solid tissue, which is well defined within the focus. And this was a multiloculated solid mass. Then coming to the solid, solid definition is that any solid tumor or a solid component, which is more than 80% more of the tumor volume, as we have in all these four images. These are completely solid, and this particular mass also shows some cystic areas. And there's these two again, solid tissue, solid masses with the cystic components, small, big, and irregular looking cystic areas inside. So the next we like to look at is the internal wall. Whether when we look at a cyst, we need to look at the internal wall, whether it's smooth or thin and regular, as we can see in this these two different unilocular cysts. Then here we have two different images, and we can see there are these solid papillary projections which are projecting within the cystic cavity. And any time when we see any solitary papillary projection, it's irregular by definition. Even in endometriosis, the wall, when there's sludge along it, it's still considered to be an irregular internal wall. In case of solid papillary projection, any solid projection which projects into the cavity is the papillary projection, should be measuring more than 3 millimeters. Then we look at its contour, whether it's smooth, whether it's irregular, as we can see in these two different images, and sometimes it shows a cauliflower-like appearance. And this is a small irregularity. This is less than 3 millimeters, so it's just an irregularity and not a papillary projection. When we are looking at solid tumors, then we look at the outer contour, as we have here pretty much solid tumor and its margins are pretty smooth, as compared to this one, which shows a lot of irregularity along its outer surface. When we have solid masses and there are these cystic areas within it, then we are supposed to look for the inner wall of the cystic component in a solid tumor. As we can see here, there's a solid echogenic focus which is projecting into this component, a pretty irregular looking cystic area. And this was again another mass which shows the cystic component with with a lot of irregularity along the margins. Now, we look for the internal texture, whether the cystic content is anechoic, whether it shows diffuse homogeneous internal echoes, as in endometriotic cyst, hemorrhagic cyst, where we have the reticular pattern or internal thread-like structures, and then a mixed sort of a pattern, which is seen predominantly in teratomas. And then we can have in this low-level echoes in these mucinous tumors. Acoustic shadow in a dermoid, here we have a mass and it's completely shadowing it out. And here we have this comet-like shadow in this particular echogenic focus, which is projecting in a cystic mass. And this is serous cyst adenofibroma, which is actually pretty classic for this particular lesion. Ascites, we look for free fluid in the pelvis, but we are supposed to where it's extending into the upper abdomen. And here we had that's when we call it ascites. After we've just done the definition and simple description, we just look at the measurements, and how we measure them is when there's we always measure in 3 orthogonal planes, which is longitudinal, transverse, and sagittal transverse views. And when the lesion appears like pressing the ovary, like this is a crescent sign, and we can see the ovarian tissue being compressed, we measure the ovary separately and we measure the cyst separately. When there are multiloculated, then we are supposed to look for the number of locules in the whole volume of the tumor. In the septum, we measure it not at the edges, because at the edges it's going to be thicker, but we take the thickest measurement throughout its course, which is perpendicular to our ultrasound beam. And fluid, we measure the maximum vertical pocket in the pouch of Douglas. When there are these papillary projections, we make sure we measure the maximum diameter. We do not measure the cyst wall, which is here we can't actually see, it's just infiltrating into the wall. So we can't get a good this thing. Here we can see that this is the wall, and so we measure this distance. When there's a solid tumor, we measure the maximum diameter of the largest solid component. Vascular features on color Doppler is like it's a subjective, semi-quantitative assessment of amount of blood flow. And this is recommended by IOTA. So we can see the color flow in the walls, which is peripheral flow. We can have it in the septum. We can have marked increased vascularity, which is randomly distributed. They're central, they're peripheral vessels, irregular caliber branching, which is pretty much classic for a malignant lesion. And then if there are papillary lesions, we look for the vascular vessels within it to actually say that these are solid lesions. Absence of flow, we have this clot and we have a dermoid, generally indicates benign lesion, but that's not always true. Here we have a cystic mass with a solid echogenic component projecting within it, but there is no flow into it. But we still have to further evaluate this lesion to rule out a malignant focus. Then moderate to abundant flow, which may be color score 3 or 5, increases the likelihood of being malignant, as we can see here, a malignant focus with marked increased vascularity. But again, I would like to add that we have to be careful, because increased vascularity may also be seen in benign masses like trophoblastic tissue in ectopic pregnancy and in corpus luteal cysts. IOTA recommends use of color flow, which is no flow, which varies from 1 to 4. 1 is no score, 2 is minimal flow, 3 is moderate flow. Minimal flow means you put in color and you see some flow, but 3 is actually it's staring at you. And 4th is where you cannot just go wrong. It's a very, very strong flow. And we have to be careful. That's one thing. We have to have the velocity scales anywhere between 3 to 6 centimeter per second, and PRF anywhere 0.3 to 0.09. And I generally like to keep it at 0.6, because if we are too low, we may be getting too much flow, or we may be getting a lot of artifacts. So this is quite important. We have to set our color Doppler settings. Now, there are these simple descriptors, which there are certain adnexal lesions which have a characteristic appearance on 2D imaging. And based on morphology and pattern recognition, we can give a specific diagnosis in more than 50% of these masses. Now, when we look at the simple cyst, it's unilocular, it's anechoic, its walls are thin, smooth, and regular, and there's excellent sound transmission. Color flow does not show any flow in the periphery. And then here we set the crescent sign. We can see that the ovarian tissue is being compressed in the cyst. The diameter is usually less than 10 centimeter and no blood flow. We already said that. So here's a 3D image, and this actually looks pretty clean looking on 2D, but when we do a 3D, there's a little bit of impression here. So we need to differentiate the simple cyst from cyst adenomas. And this is another one which actually 2D didn't show too much, but 3D was very classically showing multiple irregular projections. And this turned out to be a cyst adenoma in a 50-year-old woman. The hemorrhagic cysts, which result from bleeding inside an ovarian cyst, have a radiological features vary at the time of scanning, whether it's the amount, acute age of hemorrhage, and these have a typical pattern which varies from clot formation to clot retraction and clot resolution, and they typically resolve within 8 weeks within 8 to 12 weeks, and clinically they present with sudden onset of pain and pelvic mass. And they may be asymptomatic and may be seen as an incidental finding. So on the ultrasound, what we see are these cysts, unilocular and all this, and there are internal echoes. There are thin internal septa, giving actually like a reticular pattern, lace-like reticular pattern, and thin walls, a smooth posterior wall enhancement and posterior enhancement, which are classic for any cyst in the adnexa. They can also show fluid levels, fluid debris level. And then when the clot retracts, it shows a sharp concave curvilinear demarcation line. And these are avascular, and they actually settle in the dependent portion. The other way to distinguish a solid lesion from a clotted blood is when we are scanning. I'm sorry, I couldn't get the video to play, but when you press it with your transducer, you will see wriggling or juggling movement of the clot. And this is another hemorrhagic clot, which is a pretty large clot, and these generally have a broad base. They have sharp concave margins, and they adhere to the cyst wall and jiggles when probed. It's important to distinguish them from a solid lesion because we don't want these women to go for surgery just because there's a hemorrhagic clot which looks like a solid focus. Now they are avascular. This is a large clot, but there's no color flow in it. So we know it's not a solid lesion. And there may be there is some circumferential flow. As compared to this nodule, which is a mural nodule, and there's marked increased vascularity. And this is actually another differential diagnosis. Here we had this lady, a young woman, with completely echogenic, very smooth walls. And she'd had an MR, which didn't report it as hemorrhagic cyst, so it was difficult to do. We called her back. There was a little bit of changed texture, but I don't have an answer. I don't know what she did to this. So we have to differentiate these masses. Follow-up is one of the most important tools because here's these two images of this patient, which was done. She had bilateral multilocular cysts. When she first presented with severe acute pelvic pain. And she was treated conservatively. 2 weeks later, she comes back, and there is marked resolution in the size. We see a changed texture. So this was hemorrhagic cyst, and follow-up in 4 to 6 weeks, she was completely resolved. Coming to endometriosis, which is a benign chronic inflammatory disease defined by presence of endometrial glands and stroma outside the uterus. It has a varied spectrum of clinical morphological appearance. Clinically, they may present with infertility or subfertility or pelvic pain. They are bilateral in almost about 50% of the patient. The sonographic changes of endometrius tend to remain stable over time. That's one of the way of differentiating from a hemorrhagic cyst. Now, they can manifest as ovarian disease, which may be just endometrioma. They get deep endometriosis because when they bleed during menstrual cycle, they give pelvic adhesions, which cause these loculated collections, and they have deep endometriosis. Sometimes you can also see these hyperechogenic foci along the peritoneal reflection. And we all know how typical endometrioma presents as unilocular, well circumscribed, diffuse, homogeneous, low-level echoes or ground glass appearance. They may have thick walls. There's no solid component, and there is no internal vascularity. They may have peripheral vascularity. Atypical endometriomas generally are multilocular. So these are not multilocular cysts. These are just multiple cysts which get closely packed together, giving it an appearance of a multilocular. Then they have these retracted sludge, which is seen as these echogenic foci from the wall. And they can also have these peripheral calcifications, hyperechogenic fluid levels. Deep endometriosis may present as bilateral masses, which have these endometrial nodules, both in anterior and posterior compartments. The classic sign is a negative sliding sign, and they can go into the pouch of Douglas. This is a severe disease when it's called a kissing ovarian sign. And I think we all know endometriosis is one subject on its own, which needs a lot of evaluation and has to be reassessed very well. Now, coming to mature cystic teratoma, these are benign neoplasm arising from ovarian germ cells. They are about 20% of ovarian pathology. 50% of the women are in the younger age group, bilateral in 10 to 15% of the patients. Clinically, often they are asymptomatic and may be detected incidentally on ultrasound. They may present with painful complications, especially if there has been a torsion, infection, or cyst rupture. Serious complication and malignant transformation is rare. On the ultrasound, what they are seen as this white echogenic ball, which is the Rokitansky nodule or a dermal plaque. They may have shadowing. They may present with these dermoid mesh, which is these hair-like thin linear strands of linear densities. And we also sometimes see these dots and lines in the cystic areas. And they can present with fat fluid levels. There is generally no vascularity. Here we have the dermoid plug. We also see these linear strands of the tissue. These are classic findings, but now they have come up with some new described features, which is cottonwool tufts, which are seen in about 38% of patients. These are poorly demarcated hyperechoic foci, which we see in these masses. They may be completely hyperechoic. They may present with the starry eye sign, which is this floating hyperechoic particulate matter. And then they have, this is another new sign, which is the mushroom cap sign. There's a cystic mass, and we see this echogenic mass, which is like a curve projecting within this lesion. And that looks like a mushroom cap sign. Then there are no typical features of MCT. Those were pretty classic ones. Here we have one such patient, multiloculated cystic complex, marked increased vascularity in solid tissue. But what we see is this echogenic focus, and this is probably the giveaway sign of being a dermoid cyst. This was a cystic teratoma, but it didn't have classic features. When we're trying to do malignant ovarian tumors, they are irregular, they're solid tumors, which occupies more than 80% of the tumor volume. They're large, they're generally more than 10 centimeters. They may have a strong blood flow with the color score of 3 to 4, and they may be associated with ascites and peritoneal metastasis. And this is one such patient who had that. This is another one with multiloculated cystic mass with multiple nodular densities, which are projecting within these cystic components, which are irregular, like we said, and has a cauliflower-like of appearance. And actually, it's better seen in this magnified image. And color flow showing the color score for 4. Ovarian fibromas, again, are very classically picked up. These are solid lesions. They're attached to the ovary. The uterus is seen separately. We may not be able to see the ovary, and that's one of the differential features from a fibroid. Then hydrosalpinx, we know that these are tubular cystic areas with incomplete septum. And they have these classic signs of cogwheel, sign, this pearl and string sign, etc. And then there's a tubo-ovarian abscess where we actually cannot differentiate between the fallopian tube and the ovary. It just presents like a big complex. And when we put in color flow, there's marked increased vascularity, and that's a tubo-ovarian abscess. Now, peritoneal inclusion cyst, again, we can diagnose them just looking at the descriptors, because the history is important. They generally say following pelvic surgery or infection, and that causes additions. So what we can see here is a multiloculated cystic mass with ovarian tissue, which is being compressed within that mass. masses which cannot be characterized by using pattern recognition approach or the simple descriptors which we just talked about. And here's one such mass. I think this is the one which I started off with, and I will give you an answer to this, which is later, because I didn't get it. It is a large mass, multiloculated, solid component. And here, because none of this was implied, we can then apply IOTA simple rules. Now, there are these benign features, which are about 5, and I'll just show you on the images. And then there is these malignant features. So when we do that, we can actually, if we can't do it using simple descriptors, we can use this by using simple rules and characterize these lesions. Now, here's this 41-year-old, pretty much clean looking. This is a unilocular cyst, and one of the features of benign cyst, only peripheral vessels, no central vessels at all. Another one with which we see this focus, but this color is not picking up any vascularity. It measures less than 7 millimeters. So it's a pretty benign features. As compared to this one, it's a multilocular cyst, and she's 30 years old. There's a little bit of vascularity. It's still measuring less than 10 millimeter, and there's minimal flow. So we give it a score of 2, and these are benign features. This is actually a 26-year-old young girl who had actually just come for, she had pain in the pelvis. And this was cystic mass, low-level echoes, and we see this echogenic component, and we'll see this shadowing going down, which is like a comet shadow, acoustic shadow. And color flow shows up increased vascularity. And on 3D, it did show a little bit of irregularity. We had actually, she had to be operated the very next day because she went into severe pain, and this turned out to be the serous cyst adenofibroma. And I've been following her up. She's doing pretty well. She also actually had a baby recently. Now, malignant features, they are simple rules are the irregular tumor, there are papillary projections, which are 4 in number. There's ascites. Then there's the irregular multiloculated solid tumors, which are measuring more than 10 centimeter, and obviously increased marked vascularity, which is just random vessels which are all over the place. Now, when we use the simple rules, we can actually give a pretty much confidence in characterizing this lesion into benign and malignant in about 90% of the patient. There may be 25% where we may not be able to answer. The major problem of using the simple rules is it does not give a predicted risk. Now, here's one such patient. It's pretty much inconclusive. And marked increased vascularity, this is one which I just showed you. This has cystic components with low-level echoes, and echogenic focus, increased vascularity. Till this thing, I still think it was malignant, and I still have reported it, but this turned out to be a cystic teratoma on surgery. This morphological assessment, actually, we can give a simple risk of malignancy, which can vary anywhere from 1% in unilocular cyst to 10% in a multilocular cyst without solid component, a unilocular solid cyst about 40%, and then in a multilocular cyst, so with the solid component, it goes up from 40%. And when it's completely solid tumor, as we can see here, the malignancy risk can go more than 65%. Then we can also use this Adnexal model, which differentiates well between benign and malignant tumors. And this also helps in differentiating borderline stage 1, 2, 3, 4 and metastatic cancer. And so it gives an accurate risk estimates, improves the patient management and morbidity and mortality associated with adnexal pathology. Now, clinical predictors, they use age, serum 125, and type of ultrasound center. And basically with type of ultrasound center, they mean is somebody who's doing a lot of work in ovarian pathologies or a onco centers. Now, there are 6 ultrasound predictors which are used in this Adnexal model. One is the diameter of the lesion. The second is the proportion of solid tissue. When we have a cystic mass solid, we compare the solid tissue with the cystic component. Number of papillary projections, multiloculated cystic mass where the locules are more than 10 in number, and a solid component. And here we look for this acoustic shadow. You see these linear lines which are coming out in this solid tissue. And then presence of ascites, which we said it should be in the pouch of Douglas, but should also be going into the upper abdomen. we can feed this data. Some of the equipments have this, and one can just feed it in, and it actually gives you the risk factor at that same time. If not, this is the thing which is available online, and one can go and feed into it. Then there are these LR1 and LR2 models. This model 1 has more of clinical history, which one has to feed in. This actually goes in with the more of ultrasound features. I personally, if you ask me, I don't particularly like this regression of these models. I prefer to use the simple descriptors. I like to use what I have described so far, and then use the benign and those markers. And I would like to add in my next 10 minutes to show you what ORADS is, and I prefer that over this. So there's this three-step strategy. One step is you look simple descriptors, easy instant diagnosis, and we've just done that. Two-step is we use simple rules and combining and give a risk factor. And then we can use the calculator tool for assigning a risk of malignancy. And third step strategy is to give a subjective assessment by an expert examiner, which is more like a onco center. Now, ORADS is this American College of Radiology. They came up with this standardized lexicon, which gives ultrasound risk stratification and management system for the evaluation of ovarian and other adnexal masses. And they use the pattern recognition approach. So we have to know how to look at the ovarian or an adnexal lesion using the IOTA guidelines. And then they determine the risk of malignancy of an adnexal mass. And this is also very useful in follow-ups and in management and clinical practice. And so they have it between ORADS 0 to 5, where the ORADS, we'll just go through it in the examples. So ORADS 1, this is a 25-year-old lady who presented with severe pelvic pain. And so we started over transabdominal because in our country, we cannot do a scan on endovaginal, but she did agree to get one done. So we have both the images. So there was a large mass, complex texture, solid looking focus, and this thing, and a lot of acidic fluid. She did have some vascularity, which is within as well as outside. And but this was, can't give a complete answer. What is it? Whether are we dealing with some solid tissue or are we dealing with a hemorrhagic cyst? I still think it was a hemorrhagic cyst, but I had to say it's an incomplete evaluation. So we give ORAD 0 and we ask for MRI. Any further study we want to do, then we place it in ORAD 0. But these, and then the management is pre and post menopausal repeat study or any alternate study. Then, so this incomplete evaluation may be due to technical factors, which may be because of overlapping bowel gas. It may be inability to do a TVS, and it may be the TVS shows large size of lesions. TVS may not be able to see because it's a large lesion. It may be incompletely evaluated on an endovaginal ultrasound. Transabdominal is important to perform transabdominal examination when we can't see TVS that well. And it indicates when we can only do a TS, it's an incomplete evaluation due to size, location, or both. So and IOTA does not have any incomplete evaluation and not applicable in their description. Now, ORADS 1 is a physiological category, which we had called it earlier as normal. So they can be ovarian follicle measuring less than 3 centimeter, unilocular, they may anechoic, margins are pretty much smooth. And they may show internal echoes. They may show peripheral rim of vessels, which is in corpus luteum. Corpus luteum can present as anything. It can give you these granulated margins. It may be echogenic, thick-walled. It shows thick fluid collection in it. And it may also show peripheral rim of vascularity. They may be isoechoic or hypoechoic. And they may show fluid around it if it's a recent rupture. ORADS 1 is a physiological category, and they applies to premenopausal women. Risk of malignancy is less than 0%. No additional imaging is needed and no follow-up is needed when we are trying to manage these people. I'm sorry. So ORADS 2 is almost a benign category where the risk factor of malignancy is less than 1%. And these lesions have classic benign descriptors, which we've already been through. But one of the main thing in the ORADS is the size. They take 10 centimeters as the cutoff. So in BIRADS 2, Now here we have these are postmenopausal women, two different, and this is a premenopausal. Now this size is more than 5 centimeter, and this premenopausal follow-up in 8 to 12 weeks. Time for reevaluation is actually either immediate post-menstrual or in the early proliferative phase to see what is the changes coming up, or is it decreasing in size. Whereas in the postmenopausal women between 3 and 10 centimeter, 1 year follow-up, stable or decrease in size, annual follow-up till 5 years. And personally speaking, if I see a pretty clean looking cyst in postmenopausal, I think I would like to evaluate in 8 weeks, first 8 to 12 weeks, and then do a follow-up after a year, because I would like to make sure nothing comes into it. When there are these hemorrhagic cysts, we've already been through the descriptions. So this, when it's bit more than 5 and less than 10 centimeter, follow up 8 to 12 weeks. And if it enlarges, especially in postmenopausal women, one has to use the ultrasound specialist, gynecologist, or get an MR done. When there's an endometrioma, which is less than 10 centimeter, the recommended thing is you can follow them up in 8 to 12 weeks, but it's optional. But we do follow these patients of endometriosis regularly to make sure, once they are on medication, to make sure that they are decreasing in size and they're responding to the medication. Dermoids, whether pre or postmenopausal women, they have to be surgically removed. And if the patient refuses, if not removed surgically, then we need to do an annual follow-up. MR, if they're enlarging, changing morphology, or developing increased vascularity, which is suspicious for any malignant change. Then there are these non-simple ovarian cysts where the size is less than 10 centimeter. Now here we have a cyst which is non-simple because it has smooth, even though it has smooth walls, but it has a papillary projection, which may be roughly about 3 millimeter. This is a bilocular cyst. There's some in low-level internal echoes. And again, here we have a simple cyst, which has internal echoes and is compressing the ovarian tissue. So for this needs to be followed up, whether it's pre or post menopause, every 6 months, and refer to a gynecologist. Shorter follow-up may be considered based on certain patient clinical factors and on patient anxiety, genetic risk factors, and actually I leave it for the OBGYNs to decide what is the mode of management they would like to recommend. Now, ORAS3 is anywhere where the risk factor varies from 1% to less than 10%. It's a low risk malignant factor. And the cutoff again, 10 centimeter is what we use. 90% of ORAS lesions are benign. And whether it's a pre or post-menopausal woman, you need to get ultrasound specialists and MR. And solid lesions, which are ORAS3, one has to go to an MRI. And it is also to minimize the risk of overlooking any more suspicious features which we are missing on the ultrasound. Now, unilocular cyst, simple, even though the 10 centimeter cutoff we've used, this is endometrioma. We can see severe form because they're bilateral, they're prolapsing, they're adhesions. And here it is cystic teratoma. And MRI was done in all these things. They are recommended. Here's another one, unilocular non-simple cyst, just a little irregular along the inner margin. So when there's any irregularity or papillary projections, which are less than 3 millimeters, they have to be worked up. Multilocular cyst, less than 10 centimeters, smooth in color. We know it looks more like benign, but they need to be taken into account. And the probability of malignancy in these lesions is low. Here's another solid appearing lesion, which is smooth contour, color score was 1, and there is free fluid. So MR is recommended in all those, and this is by ORAS3. Now coming to ORAS4, these are the lesions which have intermediate risk, which varies anywhere between 10 to 50%. And these include these descriptors found to be predictive of high risk of malignancy. And here, obviously, we have to go to the tumor markers. We look for MR, we look for ultrasound, and we send them to onco centers. And management is, like I said, with gynae oncologist prior to removal or referral for management. And here are examples. There's one such patient, multilocular cystic mass with no solid component. And when we are looking at the septa in this, we should look for vascularity within this septa. So the size is more than 10 centimeter, inner walls are irregular, and irregular septation. Color score is relevant when we see the septa. And this is another patient. She's unilocular, solid component is a small focus, which is here, which picked up vascularity. And this lady actually refused to get anything done. And I still feel that she should be, because it's an ORADS 4. Now, 5 lesions which are classic for malignancy, where the risk factor is more than 50%, and whether it's iota or this thing, the risk factor is very high and they need to be taken care of. And these are some of the examples: unilocular cyst with more than 4 papillary projection, any size and any color score. Solid multilocular solid mass, and color score may be anything 3 to 4. And this patient is a solid mass where 80% of the tumor volume is by solid tissue, excessive vascularity, score 4, and ascites and peritoneal nodule. So we know these are classic malignancy and these are ORAS 5 and they need to be taken care of. I don't know if I'm running too far this thing, but I have a few cases. Should I just go through them?
Yes, ma'am.
Okay,
Yes, ma'am.
so the first one, which is 47 years old, she was referred for clinically felt pelvic mass. Now, this is if I was to describe it, I would say unilocular, solid mass. It has a smooth outline. Again, the solid tumor is more than 80% of the volume. Color flow shows marked increased vascularity with score of 3 or 4. 4 is what I would give, and there's free fluid. So when we use all this criteria and we look, and we've also said we look at the internal wall, it should be smooth and nodular in this case. Size was about 8 centimeter. And when we use all this criteria, we can say, using these descriptors, that we are this is a malignant mass. Then we can go further by using a 3D. Actually, if you ask me, 3D does not give us too much information, but I'll show you later if there is that slide I put in. But here it's 90 for the risk of malignancy is almost 95%, whichever criteria we use. This is the simplest one, which I told you, we have it in most of machines. We add the data, we feed the data in, and it gives you a 99% risk of malignancy. This is the second one with the pelvic pain, referred for pelvic, they felt a pelvic mass. So this was a unilocular solid cyst. There is this echogenic component, which when we measure it in maximum diameter, and there's infiltrating the cyst wall. Color flow shows increased vascularity. The lesion was measuring about 6 centimeters. Solid nodule was more than 3 centimeters. There was no ascites and there was no acoustic shadow, and abundant vascularity. So simple descriptors give us the thing as a malignant lesion. When we put in 3D, okay, here's the 3D. Now, what I did was, we already know it's a malignant lesion. So 3D only helps me in saying there are multiple more nodular densities which we are picking up, and we are picking up a complete septum, which we were not able to pick up on gray Sickett. But when we put this all thing together, we know it's a malignant lesion. And the risk factor, Adnexal model gave about 60%, and ORADS gave about 90%. Now, this is another patient who's 29 years old, was actually pretty young, shows a multilocular cystic mass. There are these thick septa, there are these diameter was more than 10 centimeter, number of papillary projections were more than 3, number of locules were more less than 10 in number, but there was these irregular papillary projections which give this thing a pretty much polyflor irregular nodular outline. There was no ascites and there was no acoustic shadow. And the risk of, and color flow showed increased vascularity. So simple rules: risk of malignancy, everything gives a predictive value of more than 90%. And so these lesions have to be taken care of. Now, this patient presented with abdominal distension, no pain, nothing. And this was a multilocular cystic mass. And if we look at it carefully, some of these locules or these daughter cysts are showing these internal echoes, which is like thick mucin. And sometimes this looks like a solid tissue, as we can see here. And another one here, which looks like solid tissue, but this is not solid tissue, but this is thick mucin, which is very thick to, and the color flow shows increased vascularity. So no solid component, and it also shows what we classically describe as honeycomb appearance. And thick viscous fluid, we've already talked about. Size is more than 10 centimeter. Color score is 3. No shadows and no ascites. Risk of malignancy, when we use these models, was actually quite variable. Risk of malignancy 20%, whereas the LR model gave about 65%, and I would go more with 65%, but this turned out to be a mucinous cystadenoma. ORADS was about 50% too. Another one, which is a unilocular solid mass with multiple cystic areas, diameter more than 10 centimeter, no ascites, color flow, I don't need to say, it's just staring at you. This is one of the 3D color Doppler images where it gives a complete vascular display of the color of the vessels architecture. And there's no ascites, risk of malignancy. We know it's very high, it's more than 90%. And this also patient showed hepatic metastasis. This is another patient, young patient, and she had bilateral unilocular solid masses which were measuring less than 10 centimeter. Color score was 4, risk of malignancy was 90%, but this was bilateral metastatic ovarian tumors. Generally, they are bilateral, they show increased vascularity, and most of the time they may be from the stomach. Ruckenberg tumors, the other GI tract, they may also be from breast and uterus. This was from the GI tract. She had a stomach cancer. This was another one, multilocular cyst, again, solid component, which is less than 7 millimeters, and the size is more than 10 centimeter, no color score, shadows, no ascites, no risk of malignancy was less than 10%, and this was mucinous cyst adenoma. This was just, simple multilocular cyst, nothing very classic in this, low-level echoes, no solid component, and color score, there's no shadows, and the risk of malignancy is less than 1%. I think this I have already shown you. Now, these were the two patients where I had a problem. This is the one which I told you I was not able to say. I still thought it was extremely vascular, and I still thought it was malignant, but MR should have been done, and this turned out to be a cystic teratoma. As compared to this other lesion here, by that time I realized that what I had missed in that patient was this echogenic component, which is classic for a dermoid. So this was a dermoid, and this was proved this thing. Now, just to end, one needs a careful history system. We need to do an endovascular ultrasound. We have to use the IOTA classification, where descriptive pattern recognition is very important. And that actually gives you we can characterize the lesion into benign and malignant. We can use simple rules wherever problem, and then and we have to report these lesions into benign, malignant, or inconclusive, and suggested histology wherever is needed. Differentiating between a benign and malignant mass is crucial for follow-up of these patients. So I would like to thank you. And because I'm a radiologist, I always add that we should use all our imaging modalities to the maximum before we recommend other studies. Thank you so much for your patience.
Thank you so much, ma'am. Over to you, Dr. Samira. You're muted.
Thank you so much, Madam, Manju Madam, for a detailed description of the Adnexal masses, their differentiation, usage of all the IOTA rules, ORADs. You have made the lecture very simplified and very useful for practical application. Thank you so much.
Thank you so much.
Thank you, Manju ma'am. I did my ultrasound course under Dr. Mala Sibbal ma'am. And this has been, a compressed revision for all of us. So thank you so much, ma'am. If you could please stop sharing.
Yeah, that's what I was trying to do, actually.
Yeah.
Okay. Sorry, I was trying to do that. Yes, I agree with you. Dr. Mala is the thing. I just recently met her at CUSP. And
can't hear you, ma'am. Suddenly can't hear you anymore.
It connects to the earphone. What mom is doing.
So I would like to thank you all once again.
Ma'am, thank you so much. We are really, really very grateful. And ma'am, you have your OPD now?
You asking me?
Yes, ma'am.
No. I'm here for a certain time. I'll probably leave at about 6:45 if that's okay with you.
So that means you can pitch in as my expert.
Oh, shucks, it's again back to that. What is happening? I don't know.
Yes, ma'am.
I think she has some Bluetooth connection, ma'am. It's getting connected to some other device.
To me? I'm on the thing. I'll be here for another 40 minutes or so.
Thank you, ma'am. Thank you so much. Dr. Samira, would you be here or you want to leave?
I'll be here, ma'am. It's so
Yeah.
enlightening.
So, I have two great experts with me, so I'm done. And we have four brilliant ultrasonologists. So it's going to be a panel on adnexal masses. And Jai Ganesh, I hope we all do a great job of enjoying ourselves and also entertaining our audience. Requesting all my panelists, please put on your videos. Please put on your videos. Very difficult. This Searchlight series is one searchlight on one particular topic. It's inspired by my Gurudev that, we are all in search of excellence. Whatever you do, do it excellently. Excellence in work, in interhuman relations, excellence when none is watching you. So such excellence will come only when you are not enslaved and experience true freedom and dignity. I pray we all attain that true freedom and are able to do our work without anybody vouching for it. So thank you so much for being here with me. These are all my panelists. Dr. Ashwini is in an emergency and Dr. Manoj is having high-grade fever. So I don't know if they'll be able to join, but I will introduce each one of them. So we have Dr. Ashwini, who is an MBBS MS in Gynae, and she has the membership of RCOG. She is fellowship of fetal-maternal medicine from Rangadore Memorial Hospital, Rajiv Gandhi University of Health Sciences. She has also a fellowship in fetal medicine from Dr. Adi Center. So welcome, Dr. Ashwini. Hope you are able to join. We have Dr. Sushma Meda. She's a fetal medicine consultant at Sri Krishna Nursing Home. She is also a trainee of Adi Sir, certified for NT and anomaly scans by Fetal Medicine Foundation, is an executive member of Telangana SFM and is also certified by IOTA. Welcome, Dr. Sushma. Today we are all going to test our IOTA certifications. We have Dr. Paulami Dey. She is an obstetrician gynecologist and fertility expert. She is currently consultant at Nova IVF and Fertility Raipur, ex-consultant at Deva Fertility Nagpur, Genome Fertility Center Raipur. She has a fellowship in infertility and reproductive medicine from Gunashila IVF and Genomic Center, Bangalore. And her areas of interest are recurrent implantation failure and pre-implantation genetic testing. Welcome, Paulami. I hope you all enjoy yourselves today. We have Dr. Hemani Vijay. She's an assistant professor at Sudha Medical College, Kota. We have Dr. S.R. Sandhya Rani. She is an MBBS DNB. She has a fellowship in high-risk pregnancy and is working at Anantapur, Andhra Pradesh. Dr. Manoj Jadhav is a consultant radiologist and fetal medicine at Barshi and also at Solapur. So with this, we start. Now, I was going to ask my panelists if anyone would want to describe, what is a physiological ovarian change. We see the growing follicle, we see the corpus luteum. So unless we are actually aware of the normal, it's very difficult to describe the abnormal. So Paulami, you keep doing IVF. So would you describe a normal follicle?
Yes, ma'am. Usually the physiological ovarian change depends on the phase of the menstrual cycle in which the patient is in currently. So when we see the ovary on day 2 of cycle, day 2 or day 3 of the cycle, So all the follicles, the antral follicles are usually between less than 10 millimeter in size, and the echogenicity of the ovary is not very high. And as we proceed towards the mid follicular phase, that is the day 10 of the cycle, the follicle size, what we expect in a normal responder patient without any ovarian pathology like PCOS or a poor response, is somewhere between 10 to 12 millimeter. And during the ovulatory phase, the same follicle reaches around 18 to 20 millimeter. Once we see the growing
Actually,
follicle.
listen, this we all know. What I'm saying is, what do you see on an ultrasound? You know, you have a 3 mm serous cyst adenoma and you have a 3 centimeter follicle. How are you going to differentiate that?
The follicle will be round, turgid, and it will be more of a unilocular thing. And once we monitor the follicle throughout the phase of the menstrual cycle, it will grow. But the serous cyst adenoma will be present on day 2 of the cycle, and on day 2 the follicle will be hardly few millimeters in size, whereas the serous cyst adenoma can be of any size. And
so that is the point I wanted brought out. I also want to ask you one thing. What is a residual follicle?
Residual follicle is when in the previous cycle, if the follicle is not ruptured or there was luteinized unruptured follicle, then it can be considered as a residual follicle. We have certain patients in PCO where we give SCG injections, but still the follicle doesn't rupture. And it goes up to 27 millimeter, 25 millimeter like that, and it doesn't rupture. So if it continues to be on the day 2 of the next cycle, then we call it as a residual follicle from the previous cycle.
Thank you, Dr. Paulami. And now, Dr. Sandhya.
Good evening, ma'am.
Good evening. Welcome to the show.
Thank you, ma'am.
Just wanted to ask you, by looking at the follicle once, will you be able to say that this is a residual follicle, or it is a fresh follicle, or it is a cystadenoma, or you want to follow it up?
I wanted to follow it up, ma'am.
Okay, so just a single look doesn't work, right?
Yes, ma'am.
So now I have this, I've just put the heading, it's a case of PID. And for each case, I would like each one of you, there's just 4 of you, right?
Yes.
To describe the ultrasound findings. What are we actually seeing? This has been labeled PID, but why has it been labeled PID? What are we seeing actually? This is an abdominal scan. This is a vaginal scan. What are we able to see?
Ma'am, in the vaginal scan, we are able to see a elongated cystic structure, which is adjacent to the ovary.
Okay.
And with a thickened wall, the inferior wall is thickened, and a slight septation can be seen, which is incomplete, but I'm not very sure about it because it is arising from there, but it is not reaching the contralateral wall. So it can be hydrosalpinx because it is adjacent to the ovary.
Okay. Anything else that you want to add here, Dr. Sandhya?
Along with that, tube walls are thickened, and also this incomplete septations. Along with that,
Paulami has already said. What else do you see here?
Distortion of the shape of the uterus, and also alignment, and also adhesions.
You see adhesions. You see thick fluid in the cul-de-sac. You see the ovaries encapsulated in the fluid, right?
Yes, ma'am.
This is what Madam had just explained, that whenever there is PID or infection, your ovaries will be within that fluid, right?
Yes.
So this is what is this appearance? The cogwheel appearance.
Cogwheel appearance.
Right? And this is the tube where you can see, closed in different areas. This is the tube that is seen. Now I want my dear panelists to tell me, do you see a normal tube?
Normally, no, we don't usually see the tube.
You don't see a tube. So if you are able to see a tube or something like the tube, it will automatically trigger that something is
It
wrong.
is deceased.
Right? Dr. Hemani, you want to add something here?
Here we can see the dilated fallopian tubes in the left fallopian tubes, ma'am, which indicate hydrosalpinx or pyosalpinx.
Also, what else can you see? So this patient, what do you think it would present with? Dr. Paulami?
She can present with a pelvic pain or infertility, long-standing infertility, or previous history of ectopic.
Or any surgery.
Any surgery.
So what actually, if you want to clinch the diagnosis, in this ultrasound, do you think a Doppler would help you? A color? Samira ma'am, here I think we need you.
I don't think so. Doctor may not help much.
Ma'am, if we put in color, if there is acute inflammation, you will see a lot of color, right?
Acute inflammation, yes. But once hydrosalpinx is formed, again.
But it's not just the hydrosalpinx. See, there's so much of free fluid as well. And adhesions are forming. The process is still on. So it may help a little bit. And do you think a 3D would help?
But most of the diagnosis can be done by 2D ultrasound.
Yeah, but a 3D, would it help?
Help. It adds to the diagnosis.
Dr. Sushma is also there. Dr. Sushma, would you mind putting on your video, please?
Yes, ma'am.
Yeah. So do you think a 3D would help?
3D is only an additional investigation tool, madam. Maximum information can be gained in 2D and color Doppler. In color Doppler, if it is acute PID, we'll see increased color flow and with reduced RI values.
And
also, if it is an acute PID, we can also see tube and ovary cannot be differentiated sometimes. It can be like a tube-ovarian complex. And if it is a pyosalpinx, as already mentioned by the previous panelist, we can see a cogwheel appearance with thick walls.
Yeah, that you can see it all here.
Yeah.
Okay.
So and tube and ovary cannot be differentiated. It can become a complex tube-ovarian mass.
Okay. Okay. So I would like to take Manju ma'am's opinion if she's there, ma'am. Do you think a 3D would help us here?
You know, I like to do a 3D because it delineates the hydrosalpinx very well. And also then we can see what is the part of the ovarian tissue which is involved in that. So it comes versus a tube-ovarian complex versus a tube-ovarian abscess. Because once the ovary and tube are separated, whereas in the tube-ovarian abscess, it's also like it's like a big mass. So the management, I'm not sure how will it make a difference. But I think diagnostic point of view, I think it makes a difference.
Yeah, because I actually did it on a girl just now, and the beautifully outlined tubes and all the pus in the entire cavity, in the entire pelvis could be delineated so well in the inversion mode. It was beautiful.
Yeah, that's why I said it's.
So maybe it's just my thing. I love to do it.
No. I do a 3D all the time. That's why I said that hydrosalpinx, one of the advantages is a 3D in hydrosalpinx.
So now, how are you going to follow this patient and when are you going to follow her up? This is to any gynecologist here in the group. How are you going to follow this patient? when do you want to do her scan again?
If she comes up with the complaints of infertility, her follow-up based on the symptoms, like her fertility requirements, will be managed after treating the symptoms, everything.
No, but there is so much of pus that you've seen, right?
Yes,
So
ma'am.
now when do you want to follow her up?
If she presents with pain, abdomen, white discharge, fever, we can give IV antibiotics. And after the course of IV antibiotics, we can give oral antibiotics after the symptoms subside. And once the symptoms are completely subsided, we can we can do a relook ultrasound to see if the biosalpinx has subsided.
I asked you how many days later? 1 week, 2 weeks, 3 weeks? What time do you want to give?
Maybe 2 weeks.
4 weeks.
Okay. Anybody
If
else?
the lady responds, the acute symptoms subside, follow up with oral antibiotics, give a break of 2 weeks after the course of antibiotic, and relook.
Okay. So in your experience, all of you who are expert radiologists and gynecologists here, supposing you have done a 3D, you've seen that there's so much of hydrosalpinx and everything. You've given a full course, you've examined her again in the proliferative phase in her next cycle. In how many cases does the PID completely disappear with no residue? Does it disappear or you still see blocked tubes?
Ma'am, if it's a hydrosalpinx, it rarely disappears. What I have seen in my practice, it hardly disappears. If you give a course of antibiotic also, maybe the symptoms like pain and fever will subside, but the ultrasound features, they remain same. Because it itself is a severe case if it has gone till the hydrosalpinx stage.
Okay, but here if you can see, you can delineate the tube, but you can also see, everywhere else there is fluid. So maybe the tube is not.
We are not able to hear your voice.
You didn't hear me?
No.
Ma'am, you froze for like a minute. So the last sentence which you said, we could not hear.
No, what I said was that, do you want to do a sonosalpingography on her? She's an infertile patient. She has been detected infection in her pelvis, teomas and whatever. You've done a follow-up at 4 weeks. Things have regressed a bit. Do you want to do a sonosalpingography? Yes or no?
This much pathology, do they function, the cilia and all will be lost. She may be a candidate for ART.
Directly?
We can give.
Again can spread infection, ma'am.
But it may spread the infection if we go.
Okay, so you're not doing a sono HSG after this.
Yes, ma'am.
So we go to the next case. This is a beautiful twisted ovarian cyst. So these are the signs that you would all bring up. I'm just asking you to describe the findings. What do we actually see in a twisted ovarian cyst? Which cyst actually twists? Usually when you see a twisted ovarian, what is the pathology?
Usually dermoid cyst twist.
Yes. It's a
Cyst
dermoid.
with a long pedicle will usually rotate, ma'am. Twist.
Okay, so how are you going to describe this? Hemani, if you would go ahead, describe it. What are you seeing?
And in first picture, we can see the enlarged ovaries with ovarian edema. And then blood flow is still present.
Okay. Okay. So if blood flow is present, what does it mean? Does it mean that you wait, or does it mean you go ahead
And
with
we should
treatment?
not wait, and we should try to salvage ovary at that time.
It might be intermittent torsion.
So you said edema. What are the signs of edema that you're able to see? Dr. Sandhya?
Bulky ovaries, increased pelvic congestion.
And?
Thick walls and follicular ring sign is same, ma'am.
Yes. So you have the follicular ring sign. And what is a follicular ring sign? Because of edema, the periphery of the follicles becomes more prominent. You have the whirlpool sign. You have the follicular ring sign. Can you see? All the small follicles have a very big peripheral shiny border.
Stroma is also increased, that indicates edema.
Yes. So these are the factors. How is the patient going to present to you? If she has a twist, how is she going to present to you?
Acute abdomen, ma'am.
Yes.
She will present with acute abdomen.
Okay.
With nausea and vomiting.
Yeah.
And
low-grade fever, acute nausea, vomiting.
so how would you think it is an ovarian, or do you think it could be appendicitis?
It can be.
It can be.
It can be both, right? But clinically, how do you differentiate an appendicitis from twisted ovarian? The appendicular pain will always start from the umbilicus, and then it will go down to the McBurney's point. Whereas a twisted ovarian is going to start in the pelvis only, whether right or left side, whatever. Then we have the imaging features, the whirlpool sign, the ovary, because of twisting, has shifted its position. Okay, if the patient already has a cyst and we know it, we can suspect it. And the major thing in the management, do you want to remove an ovary even if it is looking blue?
No.
For half an hour, we have to untwist it and wait for half an hour and see if it is the vascularity is coming up.
If it is not coming up, still would you like to remove it, or you want to leave
it? If it is not necrotic, we can let it be, madam. If it is necrotic and we cannot untwist it, there are already pelvic adhesions formed, then it is already very late.
You can always untwist. You can always untwist.
When there are adhesions, if there are no adhesions.
Yeah.
If it is too delayed and there are adhesions, when we cannot untwist it, and then ovary is coming off in bits and pieces because of necrosis, then there's no possibility. Otherwise, always we have to untwist and look for vascularity coming up, or even if there is no vascularity also, we can try to fix the pedicle.
Okay.
Ground ligament fixation.
Dr. Sandhya, would you like to add something here? Dr. Hemani? And
we can always untwist, ma'am.
Yeah,
and wait.
Untwist and wait. Paulami, would you like to say something here? You are an infertility person. You want us to remove the ovary, or you want us to leave it?
Ma'am, we want, if it is not twisted and the vascularity is good, then we can, if it is twisted and the vascularity is good, then we need to untwist it, and it's better we plicate it to one of the round ligaments so that it doesn't repeat and we get the accessibility.
The question here is, if it has turned blue, do you want me to leave it behind, or you don't want me to leave it behind?
We'll remove it, ma'am.
We'll leave it behind.
So the guideline today is that you need to leave it behind. That is what Dr. Sandhya, what you said is right. You do not remove it unless it is absolutely necrotic. Otherwise, you just leave the ovary. So now madam has taken iota in detail. All of you, do you follow iota or do you follow ORAD?
Iota, ma'am.
Iota, ma'am.
Trained by Mala Sibal, madam only.
Yeah. So Hemani, you are also for iota?
Yes, ma'am.
Sandhya?
Yes, ma'am. But
Follow me.
I
Paulami, what has happened to your video?
Some issues, ma'am. I don't know. It's getting disconnected. Is it? Am I visible now?
Yes.
Can I add one thing?
Yes.
We all follow IOTA. I follow IOTA. I was comparing LR model to the ORADs. I find LR giving giving more calm. I mean, I find it more difficult. That was my personal thing. But yes, you cannot do without IOTA. Pattern recognition, IOTA is the basic to evaluate any ovarian or ovarian lesion. So there's no way I would say that I do without, I mean, I don't support. ORADs is only to get the risk of malignancy.
Okay.
That's
Rather
it.
than Adnex, you would like to go for the ORAD
That's
risk?
what I said. That's why I said the
Okay.
ORADs give me a risk factor. 10%, 15%, I mean 20%. That's the only basic thing. Otherwise, you've already got your answers using IOTA. So I am a very strong supporter of IOTA. There's no way without IOTA we can go anywhere. That's all I just wanted to make this thing.
Thank you, ma'am. So that is clarified then. Then we use IOTA, but to get the risk.
Risk factor, yes.
For risk,
So
we
instead
use
of
ORAD.
LR factor, LR models don't actually give us too much information. After we've got all the information on the pattern recognition, we've used the benign and malignant simple rules. So we've got most of the information. It's only for the risk factor. That's all.
Thank you, ma'am. Thank you so much. So, now madam has taught us all very well. Fatafat, just describe, what do you see here? Pattern recognition, what is this?
unilocular simple cyst with clear fluid inside it.
Yes.
It could as well be a follicle also, depending on the phase.
Yeah, because we have not measured it here.
Yes, ma'am.
So a follicle, and you would also need to see peripheral flow. And then you could also look for the cumulus euphorus in case of follicle, which would not be present in a case of simple serous cyst. What is this? That was a unilocular cyst. This is?
Multilocular cyst, thin wall cyst.
Multilocular
Thin
cyst.
wall cyst.
Okay. Now, in this case, are these cases presenting with anything or they are incidental findings?
Mostly asymptomatic incident. Sometimes they can have pelvic discomfort or bloating.
Okay, so most of the time these are incidental findings. Mucinous may not be an incidental finding. They are usually quite huge.
Distension, abdominal distension.
Abdominal distension. So are you going to look further to whether it's a malignant case or you think this is benign and you go ahead?
No, we have to go further to decide whether it is malignant or not.
How would you go further?
Tumor markers. Before proceeding with the surgery, first we'll definitely do the markers.
Okay.
And also,
we put
vascularity in the.
You would see for vascularity. Do you want to do a 3D? Because ma'am told you, that it looks smooth, but when you put 3D, sometimes you will be able to see irregularity and nodules. So do you want to do that or not?
First in 2D, we'll take a thorough sweep.
So obviously, first you're going to do 2D. But after that, are you also going to take 3D? To confirm that the inner walls are absolutely clean?
Yes.
Yes, ma'am.
So, do you want this patient? It's a 5 centimeter cyst. Can it be done laparoscopically or should it be an open surgery?
Can be done laparoscopically, ma'am.
Okay. It's a 5 centimeter cyst is what I'm telling you. It's a mucinous
Multilocular
cyst.
cyst less than 10 centimeters.
Yeah.
It is benign role.
You want, if you do it laparoscopically, what is the precaution that has to be taken? If it's
Should
a
not
mucinous
rupture.
mass, what is going to happen if the fluid spills? What's going to happen?
Peritonitis.
Peritonitis.
Exactly. So here you have to be really careful and you have to be able to diagnose that this is a serous tumor or it is a mucinous one. Because if a mucinous fluid is going to spill into the cavity, you have actually spoiled the case. You've saved a scar, but you've given her a lot of trouble for the rest of her life. Now that tumor has been removed. Okay, the serous was done laparoscopically. The mucinous was done open with all the paddings and no leakage is there. How are you going to follow this case if it has been operated? And supposing they don't operate, then when do you want to follow the case? See, you're all gynecologists, so I'm asking you because it's not that you're just going to do the scan and leave it, right? The patient will ask you when I'm to come back. What will you answer that patient?
To see her 8 to 12 weeks, whether it is immediately increasing or if it is left behind, we have to see whether it is increasing in size or whether there is vascularity or any increase in the tumor markers.
See, she says it is benign. I'm never getting it operated. So how frequently are you going to go on?
Because there is a chance of getting transformed into malignancy, that is 20%. So we have to counsel her in such a way she'll be in follow-up.
Okay. Anybody wants to add anything to that?
8 to 12 weeks, after 8 to 12 weeks, you can for a follow-up scan.
And if she becomes symptomatic in between, we'll call her for follow-up. In between, if she becomes any symptomatic pain, abdomen or so, she has to come.
And also we have to get occult stool examination and also.
What will you get by that?
Any blood in the stools to rule out whether this is the primary site, if that goes out to be malignant.
Now tell me, what is this? Just describe the sonography findings that we are seeing. Madam has shown a very similar case. Is it unilocular or multilocular?
Multilocular cyst, ma'am.
Is it
with thick wall septation and papillary projections are also there.
Where are the papillary
dermoid cyst?
This looks like dermoid cyst.
Manju ma'am, if you're there, we would love to have an input from you.
There is a Rokitansky protuberance, as Ma'am said.
I don't know. I think it's like a multilocular cyst, mucinous cyst adenoma is what I don't see any dermoid tissue.
Yes.
Or where is the echogenic focus in these images, which for a dermoid, you have to see that unless you're talking about this one. I mean, it's not fully projecting, but just looking at these images, it's a multilocular cyst. It has these cystic areas which have differential internal echo like a thick mucin. And
so this is a case which you would like to investigate further, right? Is she a candidate for MRI and Dopplers?
Doppler, yes.
Doppler, yes. And MRI. And if this is 10 centimeters, exactly, neither less nor more, what is going to be your mode of treatment for her?
Laparotomy, ma'am.
Further evaluation by MRI.
So only if it is less than 10 centimeters, we keep it under benign in the rules. So if
It's
it is not less
exactly
than
10. It's not
yeah, so
less,
that
it's
means
not
it
more.
is
It's
not
10.
so it
So
is
do
still not less
actually
than 10 centimeters.
Inconclusive.
It is inconclusive. So it could be borderline also.
Yes.
So we would want to do a laparotomy.
And you want to do Dopplers. Is there any role of CA125 or CEA or any other tumor marker?
Yes, ma'am.
In epithelial ovarian tumors, CA125, like both in serous and mucinous cystinomas.
Okay.
CA125 normal value is less than 35. Between 35 to 80, it can suggest borderline tumors. More than 80, it can suggest malignancy. Though it is also increased in other peritoneal irritations.
CA125 has role majorly in post-operative like follow-up rather than in diagnosing it.
You know, we have all read this is a simple, this is borderline, and this is malignant. What is borderline actually? What does borderline tumor mean?
It does not invade stroma.
Yes.
There is no stromal invasion on histopathology. But
Yes,
it has nuclear cytoplasmic atypia. And it has a high mitotic index.
Not more than 4 per hyperfield. And cellular pleomorphism is seen. And these are very indolent in nature.
So I'll tell you about one of my cases. She was a borderline tumor, which was like the size of a big cricket ball. We operated it, removed it, turned out borderline. And then she went for IVF after 10 years. For 10 years, everything was all good. And she had 6 cycles. And then she came to me when she was 6 months pregnant and her whole abdomen had malignancy spread. We lost her with the pregnancy. So we always say it's borderline, it's indolent, you can follow it up. But we still have to be careful about the treatment we are giving to that patient in the future, because it does have malignant potential, right? So this is a serious borderline tumor. She had PCOD before. Can you describe the findings?
Unilocular solid. There
Yes.
are papillary projections which are more than 3 mm, though it is not measured, it appears that it is more than 3 mm from the internal cyst wall. So we can see papillary projections and it is unilocular solid. And on color Doppler, we can see that there is color flow on vascularity seen.
Yes. And in each papilla, there's a single vessel.
Yeah.
So what do
Can
you
we
think?
take it as color score 3, ma'am?
Yeah, color score 3. We would call it color score 3. So what do you think she's going to present with? She's 42, right?
It can be asymptomatic, but here we can see 3 papillary projections. But if there are more and if it is malignant, she can present with loss of weight and dyspepsia. And again, abdominal discomfort and mass per abdomen.
Most of the time, she's a case of PCOS. She would be having irregular menstruation and she would actually come for that, for follow-up. So how are you going to manage this case? You're going to remove only the ovary. You are going to remove both ovaries and tubes and uterus. What are you going to do?
She's a 42-year-old. If she has completed her fertility, we would do a laparotomy because it is more towards, because in this one section, we can see 3 papillary projections. If we take more sections, it will definitely be more than 3. So that would go in favor of malignancy. We would do a laparotomy, and in the laparotomy, we would do, if she has completed her fertility and she doesn't have any issues with conserving her fertility, we would do a radical surgery with TAH and BSO and infracholecomantectomy and peritoneal multiple biopsies.
Isn't that too much for a borderline tumor?
But a frozen section biopsy we would do Intraoperatively, we would do frozen section biopsy, and only intraoperatively when we can.
Actually, frozen section is not really available everywhere.
Or else we can do a hysteroscopy guided endometrial biopsy before proceeding with a major surgery.
You've done the endometrium, but how will the endometrium help in this? This is a
Madam, can we-
borderline tumor, right?
Can we, without frozen section, can we actually say it is a borderline tumor?
No, without histopathology.
Without histopathology, we cannot declare
So
it as
basically, we
borderline.
all agree that we are going to remove that ovary.
Yes.
Yes, ma'am.
And also tube.
As she
And
has completed.
ideally both tubes. Okay, so when we have to take her consent, it has to be to remove the ovary and both tubes and explain that we will do a surgical staging and accordingly you might have to undergo another surgery. Right? Or you want to just go ahead and do everything?
If she has completed her fertility, madam, if she has not, yes, we will wait. But if she has completed her surgery, maybe we'll straight away go. Maybe she might not want to go for a repeat surgery.
At 42
Counseling
years,
is the basic
42
thing.
years.
Yes, Dr. Samira?
at 42 years, completion of family life in our country where the follow-up is a problem, maybe it's better we go for radical procedure, like removing all and staging.
Ma'am,
And also we have to consider,
omentectomy, para-aortic lymph nodes, complete pelvic lymph nodes. It's a major surgery with its own morbidity and mortality.
family history has to be taken into consideration. MRA also to be done. Evaluate completely, and we can take a call depending on that.
Okay. So now we have the, sorry for the spelling mistake. This is it. This so anybody can describe.
Irregular cystic mass with thickened walls and ecogenic fluid and solid components in the
Multiple papillary projections and vascular.
capillary projection with solid components.
And
Cauliflower-like, it is cauliflower-like.
and it's very big. Okay. 15 centimeters by 12 centimeters. Can you see this? The vascularity?
Vascularity, yeah.
Grade 4 vascularity.
So, and this is what happened on surgery. Can you see the vascularity?
Yes.
So, what is, see here the dimension is written. It's not very big.
Is this a different case, ma'am? Because the
Yeah,
previous
this is a different case. That was a different case. This is a different case.
Okay.
So these are the findings that you see. It's a small ovary, 3.8, 2.3, and 3.6.
Essentially normal, ma'am. Normal size, actually.
Yeah, so then if it is a normal size thing, what are the pointers that are telling you that this is not normal?
Vascularity.
Vascularity.
And irregularity of the ovarian surface.
So here what is most important is the irregularity of the surface, and this will be an interface in the cul-de-sac, right? In the cul-de-sac, there is an interface between the fluid and the ovarian margin. And here you can see it's so irregular. That is what you should be able to search for in an ultrasound and make out. Madam had shown that it's so irregular in that area. This is a pregnant patient. She is 26 years old. And she has turned up with this. She is 18 weeks pregnant. What are you going to do?
We have to explain to patient, ma'am.
She had come for an anomaly scan. And in that anomaly scan, the adnexa was seen and this was seen. Okay. So how many of you would actually look at the ovaries when you're doing an anomaly scan?
No, ma'am, not in anomaly scan. In early pregnancy and in NT scan, we look for ovaries, but not in anomaly scan because by then, I don't.
We actually don't look at it. We assume that it has been seen before, even if the patient comes to us for the first time at 20 weeks, right?
Yes, ma'am.
So this is an eye-opener, and that is why I kept it here.
Suppose in the first trimester scan, if anything is seen, we follow up in the
Yeah.
second trimester.
Yeah.
But ma'am, if you have findings like this, would you know, what would you want to do? You want to take the patient to 9 months pregnancy, or you actually want to look for that ovarian cancer and treat it? What is your option? See, patients will usually follow what we say. So what is the way that you're going to counsel her? That's my question.
If there is high suspicion of malignancy, I think we should do a surgery and at least a biopsy.
Okay, if you have seen, it is already on the outer surface. There is fluid collection. So it's already like 1C is already there. So do you think neoadjuvant chemotherapy would work better?
But she's pregnant.
On the
So what
18 weeks.
surgery would you do? Just
Maybe we should advise termination and then go ahead.
So then you would, if it is already spread into the peritoneum, you need an MRI, you need a CT scan, then that pregnancy is not what you're going to think about. That has to be understood. I told you the example of my patient, right? She came at 26 weeks, the whole abdomen was full of tumor, and we lost her in 3 weeks. Neither the mother nor the baby could be saved. So what are we going to do? She is at 18 weeks, and you've detected a lot of free fluid, you've detected a tumor out of her ovary. What are you going to do?
Terminate the pregnancy, do CT scan and do staging, and based on the staging, we have to
you are going to look at the mother. The basic question is you're going to look at the mother in this thing.
And counsel her, explain to her everything, explain the seriousness of the situation, and then proceed further.
Okay. So now we are at the end of our session, and I would like to have a take-home message from each one of you before we end the session. Hemani, I start with you.
So in Adnexal Masses, ma'am, I think 3D color sonography is important. So we should do 3D sonography also, ma'am.
Okay. What will you achieve by that?
Sometimes, ma'am, the smooth wall which appears on the normal 2D sonography, which appear irregular in the 3D, and some nodules will also appear in the 3D.
Okay. Now I come to Dr. Sandhya. Yes, Dr. Sandhya?
I should try looking to at the ovaries even after first trimester scan.
Okay. And we need to brush up on iota off and on.
Yes.
Paulami?
Ma'am, while describing any adnexal mass during a routine ultrasound in any patient, be it a pregnant patient or an infertility patient, we need to describe it according to the iota rule. And we try to include more into our reporting thing. We all know the iota, benign, malignant, and all those things, but most of the time, I myself do not give it while describing the mass how we described it today. It should be a routine practice for all of us. Include that in our practice.
Ma'am, your voice is, you're muted.
Yeah, Sushma?
Yes, ma'am. So we always have to evaluate Adnexa with color Doppler, but actually it's not color Doppler, but power Doppler should always be used. And particularly PRF should be kept at 0.6, as Madam has said before, or below 0.6 or lower to look for vascularity. Because if we use color instead of power, and if you use higher PRFs, vascularity might not be seen, and we might mistake a solid lesion as a like a simple cyst or something.
Yeah, that's very important to have the correct PRF. And I come to you, Dr. Samira, now.
So, IOTA is a boon to all of us for understanding the pathology, and routine implication in the practice is a must to have good results.
So in the end, what we all need to learn is to actually describe the masses correctly. First thing is to look for them. Second is to actually describe them so that we get into the habit. And when we do it point-wise, we will also get more take-home messages. We'll be able to diagnose better. And Madam said that the Adnex model, the LR1 and 2 is available on your machines. So all your machines already have it. You just need to ask the company from whom you have purchased your machine to unlock it. Once it is unlocked, you will be able to use it. So thank you so much. I hope we have enjoyed and learned something today. Thank you, Samira ma'am. Thank you, Dr. Narendra Malhotra sir. Thank you, Manjula Virmani ma'am. And thank you so much, Dr. Sushma, Dr. Paulami, Dr. Hemani, and Dr. Sandhya Rani for sparing the evening. Thank you, Purvi, for setting the whole program in line. I request everyone just to put on your video so we take a photo. Paulami, just a second. We take a photo before I end the session.
Thank you very much, ma'am, for giving us this opportunity.
Thank you so much, Asha.
Thank you, ma'am.
And hearty congratulations again. Looking forward for a great work.
Thank you. Sarita ma'am, you've been here. If you would like to say something. You're muted, ma'am.
I joined very late. I couldn't attend the whole session because I was busy.
Yeah, but whatever you heard, if we have any feedback, thank you so much for being with us.
It's very informative. Whatever I heard was the last few slides regarding complex cysts and simple cyst, mucinous ovarian cyst, and their treatment. How should we treat them? And if there is a twist in the ovarian cyst, we should go for 3D ultrasound, and accordingly we should consider whether it is malignant or benign, and it is a malignant cyst or a benign cyst according to the its features in the ultrasound, and we have to proceed according to it.
Thank you, ma'am. Thank you so much, everyone. Thank you, my viewers, for being with us week after week. We meet again next week with another disease in pregnancy. Probably we are doing cardiac disease in pregnancy next week. So meet you again next week. Namaskar.